It's a cross section here. Blood-brain barrier is endothelial cells. Here's the pericytes. Is some sort of stem cells, the green one. Here the CSF, the ventricles, and the lining ependymal cells here. And here among them is a tenocyte. And in the CSF is the two lymphocytes here. And some macroglial cells and stem cells. Here is the dura and the arachnoid villi, and cap cells is the yellow one, bone. So the tumor is making a niche and angiomatosis here, and proliferation of tumor cells here is green, and some sort of other peculiar cells helping the tumor or for fighting with the tumor. Here is a niche, and this niche with the angiomatosis, and the tumor grows from this niche. When we come to gliomas, we grade it differently from other cancers. We don't use phases, we use grades. Grade 1, grade 2, grade 3, or grade 4. This classification is using all around the world and is special for CNS tumors. Gliomas, when it's come from grade 1, mostly in the cerebellum, in children or young adults. We also call this juvenile pilocytic astrocytoma. It always comes with the cyst and yellowish fluid in it and a mural nodule. If you remove this completely with cyst and the mural nodule, then we can cure the patient. You can remove this because it's circumscribed, very easy to remove, and there is no need to any other further treatment. It can be in the cerebrum as well, and in other areas. But mainly, grade 1 is specified for the cerebellum. When we come to grade 2, it mainly comes from the lobes of the cerebrum, can be in the cerebellum as well, and the other parts. It's well circumscribed and easy to remove, but sometimes it's diffuse and not too easy to remove. This is low-grade gliomas. In this case, almost every grade 2 low-grade gliomas upgraded to grade 3. Its survival time, and here grade 1 is patient lives, if you remove this tumor, there is no the limit of the time left. But in here, it's the survival time is about 10 or 15 years, because it's upgraded to grade 3 about 10 years later, almost every grade 2 tumors. Grade 3 is malignant one. It's not a benign. It's infiltrative, mostly not easy to remove all of them completely. If it's in the eloquent areas, we have some eloquent areas. Every part of the brain is eloquent, but spatial sites are not easy to remove the tumor, because the only treatment for gliomas good treatment is surgery. We have to use other forms of treatment like radiotherapy and chemotherapy later on. We call them high-grade gliomas. In grade 4, is more malignant, most malignant tumor of the gliomas. We call it glioblastoma. Formerly, we call glioblastoma multiforme, meaning very multiform appearances. Here you see some infiltrative features in glioblastoma. We have many problems to treat this type of gliomas, even now. Surgery, chemotherapy, and radiotherapy, if you use both of them, the survival time is not more than 1 year. So we have a very much problem for grade 4 glioblastoma. We use formerly Roman numbers like this 1, 2, 3, 4, but after 2021, the WHO, the World Health Organization's classification, we use Arabic numbers here. You see grade 1, 2, 3, and 4. You see some pictures of these gliomas. It's an intrinsic tumor within the brain. It's not extrinsic or outside the brain like meningiomas, which is a benign tumor of the brain tumors. It's inside. And heterogeneous, you see much more features in the macroscopic appearance. Necrosis, angiomatosis, edema around the tumor. You see some circumscribed features here. You may remove this one completely with surgery. You see the shift of the brain and the ventricles, deforming ventricles. In the bottom here, you see the cystic cerebellum pilocytic astrocytoma. I said before, it's the grade 1 tumor. That's a benign tumor. If you remove this mural nodule and the cyst, it cures. There is no need any further treatment. Here you see some microscopic appearance of gliomas. Here you see the astrocytes, making an astrocytoma near the vessels, mostly. It's the astrocytoma, a type of a glioma. Here you see oligodendrocytes making a oligodendroglioma. This type of tumor is more benign features because you can treat with either radiotherapy or chemotherapy. Here you see the ependymoma cells making an ependymoma. It's mainly arising from the ventricles because of the origin of the cell lining ventricles. Okay, ependymoma. Here is the glioblastoma, the most malignant tumor. You can see angiomatosis here, mitosis very frequently, giant cells. There is no necrosis here shown, but necrosis, if it's there, have a necrosis, then a neuropathologist called this tumor is glioblastoma. This is the old picture using multiforme. We don't use this word anymore. Okay, only glioblastoma. Well, neuron has a tumor as well. It's very, very rare, extremely rare tumor, neuroblastoma, tumor of the neuron itself. It's a primary neuroblastoma. I'm now about 40 years in my surgical life. I have only operated this tumor, this one. As a child, very aggressive tumor. You see uh, from the cortex coming like an abscess, looking like an abscess. When I'm in resident, I operated this child, but it's not treatable. We lost this child in 6 months. Very, very extremely rare primary neuroblastoma. In my institution, we have only 4 neuroblastoma, primary neuroblastoma. Secondary neuroblastoma, more common because of the adrenal glands metastasis to brain. We mainly see gliomas from the supportive cells of the brain. And some, in your level, is the clinical is more important. So I show here the herniations. If the tumor localized in the subpretentorial area can have a herniation below, the tentorium, tentorial herniation here, subfascian herniation because of the tumor, the mass effect of tumor, and the peritumoral edema. When it's in the infratentorial part of the cranium, then it have a tonsillar herniation if you don't treat this type of. This is very important because you have to operate as soon as possible when it's located in the infratentorial location, because you can lose the patient from the tonsillar herniation or upward or downward. And some clinical effect of tumors. If the tumors, gliomas, this pretentorial region, and the intertentorial tumors, they all have signs of symptoms of raised intracranial pressure. That's common signs. But when the tumor is in the supratentorial area, you can see the tentorial herniation. And in clinical, the lobe syndrome is the opposite side. And the one to most upper cranial nerves on the contour side. And infratentorial tumors have hydrocephalus. In adults, the clinical features of the hydrocephalus is dementia, ataxia, and urinary incontinence. A patient had this triad. You can say that she or he has a hydrocephalus, but it's not. Maybe it's for the normal pressure hydrocephalus. May not be have a tumor, but you have to differentiate, diagnose first to exclude the tumor, mainly in the infratentorial lesion. And we have seen the cerebellar syndrome on the side of the tumor, ipsilateral. And we have epilepsy with the supratentorial tumors. Especially oligodendroglioma have epilepsy. And we use MRI for diagnosis, and before operation, we calculate and make the operation using this MRI features. Here is a malignant tumor, glioma. It's the glioblastoma. You see heterogeneous appearance here, peritumoral edema, and necrosis, contents enhancement here, very malignant tumor. We use physiological appearances to remove these tumors. We use sulcus, transcortical, so superficial here, transphyllian fissure, and transcallosal approach to deep lesions, as shown here. But sometimes tumors, it's not like here, the circumscribed features. There may be diffuse or deeper in the brain. We use stereotactic biopsy technique here, you see. Not using the general anesthesia, and only it's two here. And you got the biopsy, and this is enough to neuropathologists to do the diagnosis. And then we use other types of treatments. We can see gliomas not only in the intracranial area, spinal gliomas is shown here. They are mainly benign gliomas. It's an ependymoma here. You can remove this tumor very easily, not disturbing the caudate. Okay. In caudate here, you can remove this also is an ependymoma, type of glioma. It's coming from the central ependymal lining cells here, and we saw a lot of this type of film terminal ependymoma. Here is the intramedullary astrocytoma. This is difficult to operate. It's not so easy. Here is the circumscribed type, but they are mainly diffuse ones. Only we have a biopsy. But there is no any very rare malignant grade 3 or grade 4 in the spinal cord. We use World Health Organization classification for tumors around the world. This is the last edition of the classification and comes 2021. Now here, the most malignant glioma. Here you see the real tumor enhancing and the peritumoral edema here, making the shift on the other side and deforming ventricle here. And the most effective treatment is surgery. Now you see total excision of the tumor here, and we gave radiation therapy and chemotherapy. When we get this treatment, we have seen after 6 months or so here a recurrence. And patients' survival time, as I said before, is not more than 1 year. Only 5 or 6% of patients can cure, mainly the female patients can cure this type of glioma. We have a lot of problems with treating glioblastoma. Because you see here the tumor core, as we see here. But some tumors have tumor cells far away from the tumor core, in the parenchyma, in the edematous parenchyma. This is the reason that they recurs later on. So we have a lot of problems, but we are some lucky cases like this, blood-brain barrier have physiologically not have in pineal region some parts of the brain. So the chemotherapy can affect very easily, and this case we don't use operation, only chemotherapy. The result is very good. The tumor is gone here. Only the chemotherapy. So impact of radiation therapy and chemotherapy in some sort of these patients is but when the glioma is in the parenchyma, is very hard to treat because of the uh, blood-brain barrier is not broken, so it's not easy to chemotherapy agent coming from the bloods to the tumor. We have a lot of problems there. But now in molecular evaluation, we have got good results in oligodendroglioma. Here you see a patient here on the top and the other patient here. It's both oligodendroglioma. There is a lady, one lady, starting with a low-grade glioma here, oligodendroglioma. We operated, we removed completely, but after 4 years, we got grade 3 and then grade 4 tumor. And we lost this case because she haven't 1p 19q deletion in the molecular evaluation of the tumor. In this case, this man, even his tumor is very, very hard to operate because it's so diffuse. We only have a biopsy in this case, but he has a 1p and 19q deletion. And he's still alive. He's still alive. So it's a better prognosis if you have a 1p and 19q deletion. And both patients got same treatment, but we lost this case. But this case is still alive. So we use molecular evaluation in some cases, and that help us to treat the patients better. Now, what I can say you to work on gliomas, I strongly, you may use animal models or spheroids, but I strongly advise you to work on mitochondria. You may, better than, your knowledge will be better than me about mitochondria, I suppose. But mitochondria is not only the energy source of the cell. It's a lot of functions, important functions in our lives. So the cancer, neurodegenerative diseases, Parkinson diseases, Alzheimer diseases, neuroinflammation, and cancer, all kind of cancer. Mitochondria plays a key role. Here you see the complex 1, complex 2, complex 3, and complex 4 and 5. 5 is the ATP synthase, but these are the electron transport chain. So now we know many agents here. You may use this and do research on mitochondria. If I were you, in your age now, I go to a mitochondria center and work there to find out what's the role of the mitochondria and glioma, mainly the glioblastoma. This is my internet homepage. You can visit this page, and there's a video, YouTube videos. You can.
Thank you, Professor, for sharing your knowledge about gliomas. So, do we have any questions from audience?
Nobody interested?
I think we don't have any questions.
Do you have any question?
Yes, actually, I have a question about mitochondria. So, Professor, you said that starting a research on mitochondria and its relation about gliomas and glioblastomas. So, what can we say about its relations with gliomas and glioblastomas and mitochondria?
Yeah, you can watch my presentation for neurosurgeons. Mitochondrial and glioblastoma is very interesting, very amazing. As I say, when if I were you in your age, I go to a center. There is a lot of centers working only on mitochondria because it's very important. All of the processes you may think because mitochondria has a DNA, its own DNA, and it's in the evolution, it's a bacteria and a symbiotic relation with the cell, and it's very amazing. We don't know the relation, but there is a strong relation with the cancer, all kind of cancer. I use EMP, adenosine monophosphate, for glioma, get very good result. But at that time, I don't know the effect, the impact of the way why we get so good result using EMP. When I study on mitochondria, I really realized that this second messenger is a role, it's a main role with the mitochondria. So I really strongly advise you to work on mitochondria. You can use other diseases doing research on mitochondria, not only gliomas or brain tumors, any kind of cancer. Key organelle in the cell is, I think, after 40 years, is mitochondria.
Okay, so Professor, can we say that the mutations are related to mitochondrial DNA mostly, rather than like the general DNA of the cell? Can we say that?
Yes, in research doing show that the complexes 1, 3, and 4 coming more than mostly from the mitochondria, and the mutations on this complexes, it must have more than, is much more in glioblastoma. In complex 2, is coming to DNA material coming from the nucleus. A few mutations in there. So that's the, I think we should study, study much more on mitochondria. Any kind of cancer. There's a lot of work done with thyroid cancer, pancreas cancer, but a few. So much people have to study and get the same result.
Thank you. I think we have a few questions, and Mahmoud, I think, raised a hand. Mahmoud?
Yes.
Yes.
Hi. Uh, First of all, thank you for an amazing webinar. Secondly, there are some new research on how to use electromagnetic waves and or ultrasonic waves or sonic waves to higher the permeability of blood-brain barrier and to treat the tumors more effectively using chemotherapy or other forms of drug that weren't previously available to us because the blood-brain barrier doesn't let them through. Have you done research on that? And what do you think? Do you think that they will work? And what are we? Where are we on
Yes,
the research of them?
yes. To disturb the blood-brain barrier and make a treatment is very. I know that treatment. I don't use that one, but it's a good one.
Do you
Yeah.
have my list? Do you hear what I said?
Ultrasonic waves
Hello.
are physiologic, so it's wise to use them.
Okay, thank you. So you have an idea about this technique, but you haven't used it, right?
No.
Okay. So for other questions, okay, Fatima asked that you mentioned you saw a primary neuroblastoma when you were a resident, right? Primary neuroblastoma. Okay, is there a change in surgical approach to how it is treated now?
For neuroblastoma or
Yes.
neuroblastoma is very extremely rare. I saw only one, but I saw 1,000 gliomas. So there is no. It's the same as gliomas. It's a kind of glioma. No
Okay.
other. But the feature of the tumor is very, very malignant. There is no way to treat because it's very rare. So research is very limited. You can't get primary neuroblastoma biopsy material because you saw extremely rare. So we have problems with, but it's very extremely rare. So we have to first treat glioblastoma because a lot of glioblastoma. We have no problems with neuroblastoma. We have problems with glioblastoma because the vast majority of the problem is on glioblastoma. Still, the survival time is less than 1 year.
Okay, thank you. And someone else asked, are specific mitochondrial diseases associated with the risk of glioblastoma, or are there data on maternal inheritance?
Well, mitochondrial disease is different subject. Is well known. There is no treatment because we lost them in in 1 or 2 or 3 years of age. It's not. It's different. It's mitochondrial disease is a different type of disease. I mean, the normal mitochondria working against the cancer and with the cancer. So we have to do research on mitochondria and cancer. It's very complicated issue. I really
So,
want to, one of you have to work on mitochondria.
okay, great.
It's worth to study. It's different. It's a different world.
Exactly, yes. So, Professor, can we say that maternal inheritance is possible for glioblastomas, or we don't have any knowledge on that?
We don't know. No, I don't think so. It's different. It's different
Okay.
because mitochondria. But my patients who still on life with glioblastoma, all females. Maybe you may say that it's related with this kind of feature of the mitochondria. Maybe I don't know. There is no any evidence. The scientific evidence is lost. So I really strongly uh, advise you to work on mitochondria, not for the cancer, but any other disease. You may think any disease. It's the key part of the, because there is a lot of mitochondria, mainly in muscles, kidney, brain, heart, but every organ. There's a we live because of mitochondria. So it's very important. We don't know. We just know this energy, sport energy source of cell. Not that easy. It's very complicated and should be do research on that.
Okay, exactly.
You may see and show my video in my internet site. You know, mitochondria and glioblastoma. It's in Turkish. It's about 1 hour. The other video is about glioblastoma, all kinds of treatment. I explain them. It's more than 2 hours, but in Turkish, you may also watch these videos.
Okay, thank you very much for the presentation. Thank you. So can we open the cameras? Can we turn on the cameras so we can take a picture? The audience. Professor, thank you again for this presentation. And thank you for sharing your expertise.
And good luck to you, all of you. Okay.
Thank you very much.
But work on mitochondria. I would say that.
Okay, exactly. Yes, we should.
Don't forget that.
Yes. Okay.
Thank you, Prof. Good evening.
Okay. I think we're okay. Yes, I think we can finish this webinar.